Hey guys, how you doing? Fred Gonzalez with G&G Productions bringing you another protocol video. Today we're going to be talking about reactive airway disease, and I'm reading directly from the Lee County Common Treatment Guidelines Protocol, revised in 2021, which is the newest protocol that's out there. So if you are looking at the protocol book, make sure it's that one you're looking at. And I decided to do this one because there's quite a bit of medications on this and quite a bit of things that would call for you to use this protocol. So let's go ahead and jump right into it. And like I said, I'm using the Reactive Airway Disease Protocol. I'll bring it up on screen now so you can see what it looks like. And let's get to it. So differential impressions when you would use this protocol. For asthma and asthma-like symptoms, remember you hear wheezing, upper airway, right? Chronic obstructive pulmonary disease, COPD, aspiration. If they vomited and now inhaled what they vomited, now that's when you would use this protocol. Toxic inhalation of vapor, fumes, or smoke. So maybe structure fire for firefighters or brush fires as well for firefighters. Upper respiratory or pulmonary viral infections. What's huge now, we're running a lot into, is respiratory viruses, as commonly known as RSV. That's making a huge comeback in the adult population. It doesn't matter if you had it when you were a child. A lot of adults are getting it again and having to get hospitalized for it. And remember, RSV stands for respiratory syncytial virus. It's a respiratory virus, very, very nasty. If you don't take care of yourself, you have ongoing medical problems, overweight, you can be very, very gravely ill from it. So be aware of that. And pneumonia, we would use this protocol as well. Basic life support actions, use your universal care guidelines and your patient safety guidelines. Scene safety, RSI, make sure it's the right patient, drug, dose, not expired, all that stuff. If we need to, if they're bad enough, we would use a CPAP, continuous positive airway pressure, and we would use a PEEP starting at 5 to 7.5. I wouldn't start at 10 because that's a lot of pressure that they have to breathe against to keep their alveoli open. So let's not start with that. And our first pearl that we see under your PEEP is do not exceed 7.5 centimeters of water if they have a tight lung pathology. So if they're really, really tight, struggling to breathe, don't crank up that PEEP larger or more than 7.5. Albuterol is going to be our first line drug. Remember, that's 2.5 milligrams of the drug suspended in 3 cc's of normal saline, and that's the same dose for pediatric patients as well as adult patients. EpiPen, make sure these patients have the correct pen that's for their age and weight. Remember, if you guys remember or not, the EpiPen for children, the dose is 1.5 milligrams, and the EpiPen dose for adults is 0.3 milligrams. So before they give those EpiPens to themselves, or if they give it and you arrive on scene, ask to see those EpiPens to see if they're the correct dosage they gave themselves. They might be subtherapeutic if an adult is using a pediatric EpiPen. After we use albuterol, our first line drug is going to be epinephrine. It comes in a 1 milligram per 1 ml vial, and we're going to use a strength of 1 to 1,000. And the dose, we're going to use half that dose in that vial. We're going to use 0.5 milligrams given intramuscularly. We do not give Epi 1 to 1,000 IV. That is a large dose, very strong dose of Epi to give intravenously, and their heart could just go crazy with that, shoot up their blood pressure, all kinds of unwanted effects. So remember, if you're drawing up your epinephrine 1 to 1,000 and anything longer than a 1 cc syringe, you better redo your mouth. So pediatric doses for epinephrine, 1 to 1,000. We're going to use the 1 ml per 1 milligram, and that's going to be at a dose of 0.15 milligrams. A little side note, a little hint, a little word of advice. If you're drawing up medication for pediatric or infant patients, you do your math and you figure out that you have to use anything larger than a 1 cc syringe, recheck your math, because I promise you it's wrong. You should not be giving medications to pediatrics pediatrics or infant children, and anything bigger than a 1 cc syringe for the most part. So pediatric 1 in 1,000, we're gonna give 0.15 milligrams, which is 0.15 mLs, and we're gonna give that IM as well, intramuscularly. For infants, we're gonna use the same strength, 1 milligram per ml, 1 to 1,000, and we're gonna give that in 0.10 milligrams or 0.10 ml. That's a very, very small dose, very small dose. And we're gonna give that IM as well. For our advanced life support actions and considerations, we're going to give albuterol 2.5 milligrams and 3 cc's of normal saline. Pediatrics, the same thing. Our first pearl, when we get into the ALS portion here, if we have the persistent shark fin capnography, it's suggestive of ongoing bronchospasms. So they are tight, and we need to loosen them up because they're eventually only going to compensate for so long, and they're going to go down on us. Our second pearl here for suspected croup or laryngeal-tracheal bronchitis is when we're going to use the albuterol as well. If the albuterol does not break the bronchospasms, we're going to go to Duoneb, which has 2 medications. It has albuterol and ipratropium bromide. Albuterol is 2.5 milligrams in 3 cc's, and the ipratropium bromide is 0.5 milligrams in 3 cc's. You don't get 6 cc's of the fluid, you get 3 cc's, but those 2 medications are in the Duoneb, ipratropium bromide and albuterol. And if that doesn't work for a pediatric patient, we're going to consider a crystalloid resuscitation of an isotonic solution, normal saline, and we're going to do that at 10 mLs per kilogram, 10 cc's per kilogram. And we're going to go IV or IO. For a pearl on that, for evidence of dehydration or mobilized secretions in prolonged tight lung pathology, that's when we're going to use that normal saline resuscitation, that fluid challenge. If they're tight and signs of dehydration, remember, when kids are stressed out, they go into a sympathetic response, they breathe a lot faster, they're giving off a lot of fluids from insensible fluid loss, they become dehydrated, so we need to consider them doing a fluid resuscitation early on them as opposed to adults. And then epinephrine, again, 1 in 1,000 is 0.5 milligrams, 0.5 ml, may repeat once. So you give them 2 doses, so eventually you end up giving them the whole vial. Wait 30 minutes between doses to see if your dose worked or not. What else here? Okay, so now we've given the epinephrine, we've given the albuterol, we've given the Duoneb. Our next line of defense is mag sulfate. It comes in a 4-gram vial. We're going to use half of that, and we're going to infuse this. We're going to use 2 grams in 100 cc's of D5W over 10 minutes. We're going to infuse it. Our pediatric mag is going to be weight-based, and we're going to give them a dose of 50 milligrams per kilogram, again in 100 mLs of D5 over 10 minutes. So we're going to give them a little bit less. Once we give them that drug, we're coming down to the bottom of a barrel. Our next drug in the line of defense is methylprednisone. For adults, we're going to give them the entire dose, 125 milligrams. We depress the plunger, make the fluid go into the powder, mix it up, give it to them IV. If you've ever given Solumedrol to somebody IM, it hurts tremendously. It's very hard on the tissues. It burns very much. It burns for a long time. Even after you've given the injection, it's still going to keep hurting. Your prednisone dosage for children is going to be 2 milligrams per kilograms IV push, no more than 125 milligrams. So if you do your math and if you figure out you need to give them 200 milligrams of Solumedrol, the max dose for Solumedrol is 1 vial or 125 milligrams. If at any time you become stumped, you feel you need some assistance on this, please don't hesitate to call medical control, get a doctor online, and figure out if you are in fact doing the right thing, run it by them, and they can help you out, give you some advice, and let you find out if what you're doing is actually in line with the protocol, or if you need to deviate at all, they can give you that advice as well. We can repeat the Duoneb and the albuterol if needed 1 time. And so that's about it. So our major drugs here is going to be epinephrine, 1 to 1,000s, albuterol, our first line of defense. Our second one is Duoneb. Then we're going to give the mag sulfate, And then lastly, we're gonna give the methylprednisone. 5 drugs, I believe. Make sure the one thing I want you to take away from this is we never give epinephrine 1 to 1,000ths IV. If you're going for that IV port, once you started a line, you better rethink yourself. If anyone else is watching you, make sure you grab that person. Don't let them give that medication IV. It's very, very bad for them to give that much epinephrine mainline. It's not a good thing. So that's about it, guys. I hope you enjoyed this little protocol, reactive airway disease reading. It's, like I said, it's quite a bit of medications on here. It includes your pediatric dosages as well as your adult dosages. Remember your EpiPen dosages for a pediatric, it's 0.15 milligrams. For the adult, it's 0.3 milligrams. So if the adults use a pediatric pen, 0.15 milligrams, and nothing happened, it's subtherapeutic. That's about it, guys. Not a whole lot on here, but there is a whole lot on here. Once you start reading, it goes fairly quick. If you have any questions, comments, or concerns, please leave those below. Don't hesitate to leave any comments if you like. Remember to hit the like and subscribe button, please. And thanks for watching, guys. Until next time, Fred Gonzalez with G&G Productions. We'll see you on the next one.